You're welcome. My name is Stefan Kalisubula, currently pursuing a master's in computer science. Today I would like to present to you a preterm paper titled Multi-Class Prediction of Viral Load Levels Among Pediatrics and Adolescent HIV Patients using Supervised Machine Learning. The content of the presentation is that we are going to look at the introduction, background, objectives, recent studies, methods, results, recommendation, conclusion, acknowledgement, as well as references. HIV causes a chronic infection, and it is really haunting. And this leads to a progressive disease. We all know that we don't have a cure yet, so meaning that if one gets HIV, they live with it for the entire lifetime until God calls them. So with proper and effective medical care, HIV can be controlled and one can sustain live for a particular period of time. So in order to effective and efficiently sustain this treatment, therefore, all health workers and the entire Ministry of Health, they look at an outcome which is the viral load level. So according to the current VL levels instituted by the Ministry of Health, we have three kinds of levels. One, we have clients who have VL results above 1,000 copies. It means that those patients are still non-suppressed. It means that their viral load is really high and they're really unstable. So for patients whose viral load levels are below 1,000 copies, that category has been divided into two, whereby we have a category for patients whose VL result is below 50 copies. Most time it's called non-detected, and also another range which comes from 50 to 9,999 copies. So with this category, health workers and the entire ministry is really paying close attention to these patients, because anytime they can go back to VA results which is above 1,000 copies, hence making them non-suppressed again. Well, what's the background? So according to the global standards, adolescents 10 to 19 and young people 0 to 19, there are growing number of people living with HIV for those particular age brackets. And of recent, we lost about 150 adolescents every day. They die according to the AIDS related to AIDS illnesses. So in 2016, 91% of the adolescent deaths were recorded, and these were coming from sub-Saharan Africa. So back home in 2020, the Uganda population-based HIV impact assessment report shows that both male and female, there is a high prevalence there is a lower prevalence for the clients between 15 to 19 years of age. So which means that they are really at a risk. So the recent report by the Uganda Ministry of Health shows that there was a significant reduction in the mother-to-child transmission of HIV from 20% in 2000 to 2.8 in 2021. That is a great achievement. However, sustaining a very low viral load result requires close attention and tracking of various treatment processes that are given to these clients, and becomes complex for low resource settings or communities in Uganda today. So ministry has gone ahead to institutionalize various services at clinics across the country, and starting off with tracking the HIV status of various biological siblings, index testing of index clients of sexual partners, tracking HIV status of sexual partners at enrollment, tracking of at regimens and ARV. Viral load result is critical, and as well as its updates. Viral load sample collection date is really important. ETG regimen tracking for HIV positive clients. Intensive adherence counseling is the key. HIV drug resistance, which is done when the health workers need to find out why the patient is not really suppressed, so that they are able to make an informed switching process. Switching of clients to optimal regimens. TB diagnosis and treatment. This is important because HIV patients are more prone to other illnesses like TB and cancer, so they have to diagnose these patients, and if they have a TB case, they have to be treated on treatment. Psychosocial support, month drug dispensing. These are just cohorts of months for clients. Maybe they want to take drugs for 3 months or 6 months back. differentiated service delivery models. This is how they come and pick drugs at the facility. Either some go to the community, some go to the pharmacy if they are stable in that case. So there are various DSDM models that the ministry has instituted to hold these HIV positive clients to come and pick drugs, as well as the OPC support for the children. We know that the children could not get support from the parents, so therefore the OVC service programs that are put in place so that the young 0 to 9 can really access those services. The objective of the study is that we want to review existing studies, how they applied machine learning in the prediction of viral load results, perform explanatory data analysis, apply supervised machine learning algorithms to predict the viral load levels, compare the performance of different algorithms, identify the key services that determine the viral load levels of these patients, as well as apply SHAP if we need to know what are the driving factors per patient towards having a low suppression level. Well, recent studies show that in China, they incorporated clinical indicators into those models to predict and evaluate the immune functions and the recapitulation of HIV and AIDS patients for better guidance in the clinical treatment. There was an investigation into the potential use of XGBoost algorithm using the social behavior driven data to sustainably identify HIV predictors, as well as predict individuals at a higher risk of infection for targeted screening. So back in Uganda, there was a study conducted by Kutesa at IDI. They did a comparative study of logistic regression based on machine learning techniques for prediction of early virological suppression in antiviral initiating HIV patients. And Carol Recent did used that machine learning with routine electronic medical records to predict the people or the clients who are at high risk of disengagement from HIV, and this was done in Tanzania. So, well, diving into the explanatory data analysis and the methods, the ethical considerations that the data is crossed and the secure approval processes to engage more reviewers. This is undergoing, and the dataset consists of 10,339 clients. Those are below 19 years of age. So what we observe here is that we have the number of clients per sex. You see that we have more female than the male, and in here you see that we have more clients between the 10 to 19 because they had the low HIV prevalence of recent according to the impact assessment report. So on my extreme right, you see that the number of clients per viral load level, you see that we have very many clients who are suppressing, who are having a viral load below 50 copies compared to the other two classes. So down here on the left, we see that the number of clients per VA levels, we see that we are seeing more females suppressing compared to the male. And you see that for non-suppressed, you see that there is a head-to-head, representation. So for 50 to 9 to from 50 to 999 copies, we observe that yes, we have more females compared to the males. Okay, so looking at the number of clients per viral load levels by age groups, we see that from 10 to 19, you see that we have very many who are suppressing compared to the 0 to 19. So you see that those which are non-suppressing, we have more of 10 to 19, and this points to the earlier problem statement that we have a low HIV prevalence for 10 to 19 years of age. So on my extreme right, we see a box plot representing sex and male, but we have some areas as you can see, but you see that majority, 75% are really having weight below 50 kilograms, and to those who are between 0 to 9, you see that 75% of them are below 25 kilograms of weight. So weight is a key factor. It feeds into the outcome of a patient. Well, looking at the correlation of these variables, especially the numerical variables, we see that as age trends through, we see that as a client's age increases, that means the client is shifting from the 0 to 9 to 10 and 19, which means he's more likely to have more sexual workers, so he's more likely to have more sexual partners, and therefore the biological siblings. So if you can trace that, you're able to know their status, if they're enrolled on ART. If not, then they have to be put onto treatment. So looking at the correlation matrix, you see that those which are strongly correlated, the correlation scale relies from 0 to 1. So those which are strongly correlated, they are really highlighted in here, unlike in black. So which means that these Q variables really feed into the age, they are related to the age. Okay, so the extreme left, we see that we have the distribution of weight against viral result, and still this shows that we see that we have more females which are suppressing compared to the males as well. Well, looking at the correlation between numerical and categorical, this still points to the same picture that I explained above. So what we see from the data set is that we have 22.83% of the missing values in the entire data set. Well, applying supervised machine learning, of course, we had to perform data preparation to model. So the current VA result was selected as a target variable, and the data set was split. The data set was split in the ratio of 0.33 size. So whereby we have the test data set and also the train data set, and you see that it has 24 labels for the train data sets, and it has 6,425 clients, and also the test data set. Sorry, the test data set has 6,425 and 24 labels as well. So for the train data set, it has 3,165 and 24 labels. So we have some variables that do not have data, so we had to impute them in that case. So for categorical variables, we use the frequency rule, and also the numerical is the median rule. So categorical variables, both in the train and test data set, were encoded using the one encoder. Well, looking at the random forest, what did we observe? We observe an accuracy of 0.63%. Sorry, 0.632227. So, however, this model suffers overfitting, because if you look at the ratio of the train and the test, it is 1 to 0.64, which means that the model learns perfectly the training data set and it fails on the test data set. So what we did is that we performed hyperparameter tuning for the random forest to increase on the accuracy. So what we did, we ran a graph on n number of estimators from 0 to a certain estimator, which will give a maximum accuracy value. And in this case, we see that the accuracy increased by 34% to 0.64328 with 146 SN estimators. So looking at the confusion matrix, you see that the model perfectly predicts clients who are most likely to have a viral result below 50 copies, unlike other levels. So while looking at the graph, you see that the graph keeps on fluctuating between as the n number of estimators increase, but the maximum n estimator, which yields a high accuracy, is 146 n estimator, which gives a maximum accuracy of 0.64328. Well, comparing this random forest with other models, what do we see? We see that random forest and graded boosting are overperforming because they have a higher level of accuracy, as you can see in the table below. So however, you see that it underperforms for the other two classes, which is clients who are most likely to have video results above 1,000 copies, and also between 50 and 999 copies. So which means that there is more study that has to be done to improve on the model accuracy for these other two classes, which are not performing well. But this erodes to an imbalance in the data set that we are working with. So visualizing the main important features for the VO mount classification, we see that these key features from at start date, current VA error start date, age, current VA start date, mount month, DSDM, weight, number of biological children and siblings, the HIV status, obviously screening, the current era during main sex, VO updated, current average TPD status, age, and all these other factors, they are key in determining the VO result of the client. So meaning that if health workers pay close attention to these services to ensure that the clients get them, then we are most likely to have optimization, we are most likely to have good treatment outcomes, we are most likely to see more patients suppressing compared to the current state where they are non-suppressing. Well, using SHARP is a collection of algorithms. It just basically helps you to determine the key features the relevance of each key features towards a given target. So what we did here is that we sampled a client randomly, and this client ID was 858. And what we see in this in the sharp plot is that what strongly determines the VA result of this client is going to be the current regimen they are on, followed by the DSDM approach. Okay, so what you see on the left is that it's a higher probability in red. What you're seeing, that those are the variables which are most likely to have a higher probability to affect my target variable. So what you see on the blue, those are less, they have a lower probability. So meaning that if health workers probably look into this, they're able to say that this client, the current regimen will strongly determine the VO result, and also the DSDM approach, how this client picks up the drugs in the facility, the DSDM model used, it will strongly affect the VO result. So with this means that health workers are able to come up with the quality improvement strategies to really close this gap and say that this patient really achieves suppression at the end. The recommendation is that currently we have more than 100,000 health facilities across the country that are running Uganda EMR. This is the system that has been launched by the Ministry of Health. So, but however, the gap is that this on-premise system, it does not have these machine learning models. So if it means that we build models on top of them, they're able to cluster all those patients who have long stayed in that facility and are not having good treatment outcomes. So that quality improvement measures or strategies can be instituted to have these patients suppressed at the end. So however, in Uganda, there's limited research on the application of machine learning and AI, so which means that there are more opportunities to apply machine learning into the HIV sector. So supervised machine learning algorithms such as random forest and gradient boosting can be applied to predict suppression and non-suppression levels for HIV based on the current discussion or study done. The conclusion is that supervised machine learning models were developed to predict the early viral load levels, and we see that out of all the models tried, random forest and gradient boosting performed highly for patients who are most likely to have viral copies below 50. However, did not perform well for clients most likely to have viral result between 50 and 999 and above 1,000 copies. So meaning that there is more work that has been done in that area. So the random classifier and the gradient boosting outperformed other models that I applied. So SHARP is really important because it extensively provides the relevance of the Q features and the prediction process, and it is a fundamental in ascertaining the relevance of each ad services given to the client towards achieving a good treatment outcome. So what I'm saying is that machine learning has the capability of tracking cohorts of patients who are likely to become unstable in looking at the viral load results. So which means that the health workers are able to provide targeted services for these clients so that they are able to support at the end. I would like to acknowledge Dr. Marvin Galiwango. He really helped me to come up with a good problem statement, and he pushed me harder to look into other models, how to use them, and also how to compare them to come up with a good model that can predict and classify the VO results. I would like to thank Dr. Joyce. She has been really pushing us as well as like to acknowledge Dr. Simon, the Minister of Health, and SCAP, who has been slightly providing me some input into the statistical guidance, but more study has to be done to improve of this study as well. So those are my references I used, and I would like to thank you, and I look forward to do more work to have this published at the end. Thank you.